felt there was a very like natural engagement coming from you. But we will try to make the other sessions as short as possible, not to make you wait until the very late in the evening, especially Friday one. So for this session, we decided that, as you remember, you were on the morning session, we introduced scholars who are here with us. So we decided, why don't they will summarize and identify main issues that were discussed during the sessions yesterday and today. Why don't they, with the involvement of each of us, will identify the gaps, and then we will be able to discuss them and to translate them in a possible future, maybe research priorities or future, I don't know, initiatives and collaborations. So on that note, we had volunteers for each session, and thank you to each of you for joining this initiative. And at this note, maybe we'll start with the health financing session, which was the first one yesterday. And please join me, take on the scene, and we will be happy to hear from you what was identified as a key challenges and key solutions that you have heard. And please, when you will start talking, you may take a seat, or if you prefer, do you prefer from here? Yeah, just introduce yourself and your institution, affiliation, countries, whatever. Thank you.
I'll just introduce myself and you introduce them. Good afternoon, everyone. My name is Ngozi Akwatagibe from the Royal Tropical Institute in the Netherlands, and also Eneld Health Research and Services in the Netherlands as well. And yeah.
Hello, everyone. My name is Adrianna Lozian. I'm a medical doctor and a public health professional, research associate at the American University of Armenia.
Okay, thank you very much. Also, background of medicine and transdisciplinary global health specialist, just to say that. Hello, okay. We're going to answer look at the day one, session one, healthcare financing, and we'll do it in this way. We'll do a quick recap of what we did yesterday during that session, and then Harshel will look at the key knowledge gaps and opportunities for research. So the research question for that section was, what health financing structures enhance health system preparedness for responses to and recovery from crisis? Example, climate, health, or conflicts-affected crisis, and why? And to start that session, there was a brief introduction by the speakers to tell us why we need to adjust health financing. Because of those sudden changes that occur in times of crisis, we notice that income reduces, expenditure increases, you have market failures sometimes, and also there are usually need for certain and more diverse services, and such as mental health, rehabilitation, and things like that. And those are all things that actually flag the need for, and other things that flag the need for more effective and efficient ways of carrying out health financing. Examples were given during the session of Ukraine, Israel, Kazakhstan. Yeah, Kazakhstan, I think, also. And then also the examples of COVID-19, what was done during that period. Basic key messages, just to go straight to the point. Ensure what should we do in those crisis situations? There are different ones we've already mentioned. Ensure sufficient and stable funds to meet evolving and unpredictable needs in crisis situations. A key message here is that counter-cyclical health financing, which also includes increased government spending, that emphasis on public funds, is very critical and helps to ensure the stability of health financing. Private financing is regressive and results in catastrophic expenditures and unmet needs. And then even when you increase VAT, that value-added tax, to support health financing, that is also regressive. States have an obligation to ensure that health finances are on the basis of residency rather than contribution in order to eliminate access barriers. And in Ukraine, for instance, reliance on government revenues rather than specific contributions avoided having that insured, uninsured population division, and it mitigated the effects of the economic shocks on access to services and medicines. So we had about the key success factors from Ukraine that were good examples, good practices: centralized funding, strong purchasing, and the use of flexible payment models. So those are things that ensured sustained access to health services in Ukraine in the face of Ukrainians and the population in the face of conflicts. Another key message we got was the flexible approaches to public-private partnerships, the need for that, and also to reassess those structures after the initial urgent need. Public-private partnerships should be reshaped to comply with good governance practices after acute crisis. This will avoid negative unintended consequences. It's important in crisis situations to actually rely on collaborations with the private sector, but to do so very cautiously to ensure that the private sector does not crowd out the public sector, also leading to catastrophic spending and unmet needs. Important to direct funds where they are most needed, compensating providers for income losses. So there should be mechanisms in place to rapidly adjust payment systems to protect providers from income loss. Also ensuring that in the course of this, there is monitoring as shock-related services, evolve to become more routine services. So this will prevent overtreatment, overspending of public resources. And then there are certain shocks that really specifically affect financial access to services, such as economic crisis and inflation. There's this hyperinflation going on right now. Within those type of crisis situations, there's also need to provide some reasonable degree of compensation to providers to account for inflation. But this should not necessarily be done automatically. It should be on a need-to basis. Health-specific price indexes should not be used to update provider payments to avoid spiraling costs and reinforcing inefficient health system practices. But capital investments and investments in worker skills should be protected in those times. These are really necessary for future health system performance. And it's important to ensure that any public-private partnership put in place does not perpetuate inequities. Okay, examples of health financing strategies that were discussed yesterday that encouraged universal health coverage. Ukraine had a good example with the internally displaced persons, the IDPs. Those were more likely, or are more likely in Ukraine, to report barriers to access than the other population. The key barrier was usually the administrative burden. But what happens here is that guaranteed non-contributory entitlement to care for all residents has ensured that the IDPs remain eligible to receive services in their host locations. Another example given in Ukraine was to address the epidemiological shock. They had a very explicit and specific definition of coverage under the PMG AMP, which facilitated a very flexible response to emerging needs, including in the form of new packages for mental health at the primary healthcare level and complex inpatient rehabilitation services. So those are sort of good practices other countries can, in fragile settings, can take a look at. And of course, one key message that came out yesterday is that strong primary health care is critical to ensure access of care during war and post-war recovery, even in the face of health financing. Generally, in terms of use of other financial pathways apart from public funds, you have international donors that pour in funds during this crisis situations, UN, USAID, and then you have other extra budgetary sources and private funds like large businesses. Usually they're mainly extractive. They have their own healthcare for their staff and things like that. But the key issues in this sort of financial pathways, when they're still in the system with the public, is that there is usually a lack of coordination, pulling all these elements together to ensure a more effective process. And also, even when they're helping in the system, for instance, in Ukraine, I think the international donors are really strong there. Even when they're helping in the system, there's that need to keep in mind the insufficient longevity of political priorities. So that's one thing about those resources. Different countries are experimenting with different novel ways of financing to incentivize coordination and integration of service delivery. Also looking into innovative payment systems, pay for improvement, pay for performance, additional reimbursement for documentation, patient enrollment, etc. And those are all elements from examples from different countries that can be looked at. In terms of what's next, there's a need to strike a balance between centrally defined requirements and local autonomy. Actors at different levels of the health system are faced with different pressures. And sometimes you see the same actor, different actors in the health system having competing, incompatible and opposing priorities, yet it's the same health system. So there's a need to look into that. You also have policy intent and actual implementation, and he's going to talk about gaps due to organizational challenges in managing policy changes during healthcare reforms. So those are all things that are in the next line to look at. And also to create that policy environment to enable capacity building and competence of health workers and others who actually need to implement changes, policy changes that need to take place in the case of healthcare reforms that take place during crisis. That's just basically some of the key messages in yesterday's session. Thank you so much.
Thank you, Ngozi. So based on what Ngozi said and the themes that emerged from yesterday's discussions and presentations, we have identified some gaps and opportunities for further research. And I would like to start with the governance and policy frameworks, which we think that the effectiveness of different governance and structures and policy frameworks in managing health financing during crisis is a relatively unexplored area, and studies could analyze how different models impact crisis response and recovery. Second off is the long-term impact and sustainability. Research could explore the long-term sustainability of emerging health financing measures and how they transition into regular systems. Third is innovative financing models. We discussed different types of financing models and how they have changed during crisis, during war times or COVID-19, or even with sustainability during climate change. And traditional financing mechanisms are well documented. There's room for more research on how innovative financing models such as digital health financing, public-private partnerships, and community-based funding approaches could help. Impact of globalization. The effects of global economic fluctuations on national health financing during crisis are not fully understood, and more research could examine how global financial trends and international aid influence national health systems during crisis. And equity and access. There is a need for more in-depth analysis of how crises impact different populations, particularly marginalized and vulnerable groups. Studies could investigate disparities in access to health services and the effectiveness of financing mechanisms in addressing these inequities. Coming to data collection and metrics, there is often a lack of consistent, reliable data on health financing during crisis. Developing standardized metrics and improving data collection methods could provide a clearer picture of financial flows and outcomes, contributing to improved quality of healthcare services. Adaptation of resilience tools, understanding of how resilient measurement tools can be adapted for different contexts and what factors influence their effectiveness. And this also includes climate resilience research. Defining and measuring resilience, there is a need for standardized methods to measure resilience, including how these tools are adapted for different contexts, the effectiveness of resilience measurement tools, and their adaptation is a key area of interest. And what are the attributes of resilience? Identify core attributes of resilience in healthcare systems, including specific instances where resilience has been demonstrated is crucial. Integration with other sectors. We discussed yesterday that we do not only need to look at the problems from the lens of healthcare, but we need to have a more holistic approach. And the intersection of health financing with other sectors like education and social services during crisis is a bit underexplored. Research could look at how integrated approaches can improve overall resilience and response. Behavioral insights, understanding how crisis situations affect decision-making processes related to health financing, both at the individual and institutional levels, could provide insights into improving future responses. We discussed the cases of Ukraine, Israel, and Kazakhstan, and case studies like these are crucial, and other countries as well highlight the importance of adapting financing and service provision to meet actual needs and the challenges of measuring and managing out-of-pocket spending. Quality of primary healthcare, assessing the quality of primary healthcare service during crisis, understanding data challenges, and evaluating risk pooling mechanisms are important for maintaining service quality and access. And finally, about telemedicine, we have issues with the financing mechanisms and oversight. So more research into telemedicine is necessary to use this technology furthermore in the future. Thank you.
Thank you very much. Thank you both. Me and Adrianna just discussing that rather than to have like separate session on discussing whatever we heard from you and then to hear some reflections and possible ideas from you, why don't we stop right now on the main issues that you have identified and ask to the audience, what are your thoughts? Do you have some additional comments and suggestions what we have heard on, and do you identify some linkages? Because like before we will go to this discussion, I mentioned it in the morning, just want to highlight that the aim of this conference is to find some linkages between each other and to identify some common areas that we can work on together tomorrow or even from today. So probably it's worth now to stop and thank you both of you for the very comprehensive like summary of main issues and gaps identified on house financing. Probably now I will call to audience. If any of you want to add or suggest, or you identified for yourself some possible, I don't know, areas to work on in relation to what we have heard. So just raise your hand and we will help you with the mics. Yeah, I see hand. Can we help like with the, let me help.
Hello, can you hear? Okay, you can. Tomasz Bochenek from Kraków, Poland Institute of Public Health of the Jagiellonian University. So, using this occasion, thank you so much for possibility to participate in such interesting, stimulating event. And I think, of course, that it would be great to cooperate, develop these or other areas. I think from technical point of view, it would be great to have some kind of conference materials in any form, not necessarily full presentations, but anything from as a food for thought after this conference, or at least the list of the contact addresses of the speakers. It would be great. And I think that referring to the topic, building just sustainable and resilient health systems in times of crisis, I think it is a great, big topic. And of course, there are many areas not covered during these 2 days. There can be many seminars, and there are many areas. I have also impression that if we focus on resilience and crisis, yes, plural, there is in different geographical locations, there is different perceptions of crisis and different priorities. Yes, for Ukraine, of course, the most serious crisis is war. Yes, military conflict, but it may not necessarily be the case for Portugal, for example, and many other countries. So I think that in any there are things which are in common, but in many cases such research or focus should be specific to probably to this or that type of crisis. Or intervention. And also I would comment and say that I think that possible area for cooperation could be also academic curricula. I have impression that speaking about public health, for example, these issues related to resilience, preparedness are very minimal. They are almost not covered in teaching programs, and this is a field for cooperation using Ukrainian experiences, for example, and other countries' experiences as well. And even I think that this may pertain to other academic programs from outside of medicine, healthcare, public health. Yes, because preparedness is something which does not pertain to the silos of healthcare, for example, or medicine or public health. It is so interdisciplinary that maybe preparedness, I mean, issues related to preparedness should be included in teaching curricula of study directions, which we even do not think of now. Thank you very much.
Thank you. I think it was a great point. I will reflect maybe on the academic curricula part, because like in the region, there is not much developed like learning and studying of these professions, such as like not only public health, but like in most cases, we don't have global health faculties and so on. And what you have just said about like preparedness as the part of the curricula and in which field it should be embedded and how it should be like intersectionally linked. It's a very interesting field to think of, and maybe different academic institutions in the region should like sit down and discuss like what are the priorities for the like sub-region, how to develop those fields, and how to be as innovative as you suggested to even have this intersectoral and interdisciplinary and cross-disciplinary approach in the development of curricula. Thank you. I guess others? Yes,
Just
go
to
ahead.
add something.
You know, yeah,
Sorry.
okay. Comment and then you.
Sorry, just to intervene here for a second. Definitely on the materials, we'll speak to all the speakers. I'm sure everybody will be happy to share their materials with all the participants. And as I said in the beginning, part of our hope is to work with the scholars who have been excellent rapporteurs to try to document as much as possible, not everything that was said, but the key messages, the key research priorities and opportunities for collaboration, and the key capacity strengthening needs. And so again, we'll share that with whoever's interested in commenting on it. Just before we get to any more questions, first I'll take your feedback. I think we were asking specifically about the health financing, but just remember that we have still the primary care session rapporteurs to hear from and the governance rapporteurs to hear from. So if the questions remaining are sort of general, then fine, but also okay, but go ahead. Sorry.
Okay, thank you. No, I was talking about the curriculum he mentioned. That was really, because it came up yesterday, and there was something really important about how, about that was about the need to use that to curriculum change and adjustments, to use that to minimize the movement of the health workforce in crisis. And I think that's an important one, movement of the health workforce into the private sector, because that came up yesterday. And it's really about in terms of their skills and in terms of in certain elements of teaching about empathy into the curriculum as well. So that there's, I guess the idea when it came up yesterday was building more related to intrinsic motivation to stay, but in introducing that in academia could help us.
So my name is Mariana. I'm from Bogomolets National Medical University. It's my last year, and there was said a lot of reformation for like patients, but unfortunately I didn't hear anything about young doctors and students. And when you talk about building something in Ukraine, I guess that scientists, researchers has to pay attention that unfortunately in Ukraine, doctors who have experience, they very often dislike young doctors. And I faced in my life coming to government hospitals, working there, and unfortunately attitude to young doctors are really bad almost everywhere. Whenever you want to get good education, you are going to private clinic where you pay for your education officially and they teach you. And usually they are more kind and understandable. But we have talked about primary care, we have talked about lots of hospitals, and for me, it will take a long time to start my researches because I have to complete universities and masters. So I have like a request to everyone who helps Ukraine, who makes researches, don't think only about patients. If you pay attention on young doctors who don't want to take bribes, who want to be high professionals, and who don't want to leave Ukraine, only after that, I guess, a strong and health system can be built. And I'm really asked, maybe there will be one conference more. Don't talk about only patients. We also exist. Pay attention at young doctors. Thank you.
Thank you for that point. Okay. All right. Is there anything else? Yeah, please, Solemia.
Just going back to the health financing and the gaps in knowledge from our experience, maybe this is specifically coming from the country office, a big part of health finance or the resilience of the health system is actually the public health system. And when we talk about public health, I don't know anything about financing of public health. And I constantly have colleagues coming from the public health teams asking, okay, how do we finance this? How do we consider financing of the public health system? And I feel like there is very little and limited knowledge in this area. And I think this would be a really important gap that we start actually evolving. Because if we're talking about resilience, it's not just financing of the health system as we see it, but also the financing of the public health system that is extremely important for preparedness.
Yes, thank you, Salmi. I totally agree with you. Like on one hand, we are considering public health as a part of health system, but on the other hand, mainly concentrating on the service delivery rather than the public health. And good point, and thank you. Dear panelists, do you have something to reflect on what you? Oh, okay, we have one another question, comment.
Yes, thank you. So my name is Ruth. I presented yesterday morning on financing, and after hearing the discussions yesterday and today, I thought that maybe the questions that we should be asking in those countries that maybe have less resources than the countries that I study generally are not so much how do we finance, but how do we set the coverage with the money that we have? Because the countries have lower resources, and it's obvious they cannot afford to finance all the services and everything that we would wish. And maybe the question of coverage and how to set benefits baskets, and the exercise that Ukraine has been doing since the war of creating this benefit basket, this is something that other countries could be doing, or they are doing, and we just don't know that enough. Or we could try to think about the best way to create the coverage. It's not only about the services, it's about the populations, the level of funding, right? So maybe together with financing, coverage should be a key aspect. And given that we don't have all the money in the world, we have just this money, what can we do? How can we best use it? And I spoke yesterday about health technology assessment and trying to finance the most cost-effective services and primary care. I don't know this field. Maybe this is something people are already studying and I just don't know it. But probably this is very important for the less rich countries.
You're making me think of a book I think your colleagues wrote called Good Health at Low Cost. Maybe Martin and Dina, in fact, but I think, no, absolutely. Well,
Yeah, and Maia Rose, just to complement on what you have said, like on low-resourced countries, probably such as ours, I'm representing Georgia, how priorities are settled. Yes, this is like the same question, I guess, which you mentioned. And in some cases, they are very linked with the political agendas. How to make electorate happy for the cycle of elections. And sometimes this is very interesting dynamics, and maybe to research and study more on that, and then to enforce make decision makers to make decisions in other way, it will be very beneficial for the region. Thank you for highlighting this.
So I think I'm only, I hope I don't seem like I'm rushing people, but I'm conscious that we were an hour behind and I know people have flights to catch and so on. So I think we should probably move on to the next two sessions, if that's okay. Yeah, okay. Thank you so much. Primary health care, please, yeah. And maybe just in the interest of time, we can focus on the key gaps and priorities and maybe less on the summary of messages. Yeah, okay.
Yeah, I prefer to. Sorry, I want to open this document, but something wrong here.
So, Alex, are our participants still online? Maybe some of them would like to contribute as
It's
well.
some antivirus,
And also, Alex, can you help us? Maybe this is, sorry.
but it is not because
Okay.
of this. And
Alex, can you help us with the technical issues? And also, if we have online participants, please go ahead on both sides. If you have questions or if you would like to answer questions or just.
It requires renewal and because.
And meanwhile, we are dealing with some technical issues. Okay, I guess we are fine.
My name is Simon Gabrichidze. I represent Tbilisi Institute of Global Health and NCD Alliance of Georgia. At the same time, I work and teach at the University of Georgia, health economics and insurance. I have background in public health and health management. Together with me, also Uchaneishvili and Adrianna, I hope they are in the, has taken notes and they shared them with me, and I have prepared some summary documents and would like to highlight some major points that was raised during the second session on the primary health care. So main question that we tried to answer during the primary healthcare session was the following. How are primary healthcare oriented health systems better able to prepare for, respond to, and recover from the crisis? And what are the essential elements of resilient primary healthcare system, and how do we achieve this in time of crisis? As it was discussed yesterday, primary healthcare-oriented systems play a very crucial role in strengthening our capacity of health system to prepare for, respond to, and recover from the crisis. These systems enhance resilience, equity, responsiveness, which are essential during the health emergency. However, building primary healthcare systems should be started much earlier before the crisis. And experience showed that not all countries in our region properly realize the importance of strong primary healthcare systems. As yesterday, Pavlo Kovalyuk noticed, only in 2018, Ukraine started implementing real reforms in the primary healthcare. In some countries in the regions, initially starting these active primary healthcare reforms, but then it was slowed down, or in some cases even abandoned, like in our country. So I would like to summarize the following main points: how primary healthcare contributes to crisis preparedness and responses, and to what extent it supports health systems in crisis situation. First point I would like to mention is the developing a strong primary healthcare workforce. It's very important. Experience of Ukraine has shown that improving financing of primary healthcare not always leads to better quality of care. We should not forget about capacity of health workforce and address it simultaneously. A well-trained, adequately staffed, and supported workforce is crucial. This includes training in, for example, in crisis response, mental health, and chronic disease management. Second point is the community engagement and trust. As it was mentioned many times yesterday, trust is very important in general, but it is especially important in the when we are talking about primary health care. If people don't trust, they simply will not apply for primary health care providers. We have many cases of that in our region. So building and maintaining strong relationship with the community ensures that health messages are trusted and the community is involved in health decisions, which is critical during the crisis. We talked about also task shifting yesterday. It was lots of the some discussion about task shifting, which has a large potential, is crucial resource to employ during time of crisis. However, it is important to develop relevant guidelines and clearly define the roles of each specialist involved in this process. Next point is related to the multi-sectoral collaboration. Resilience requires collaboration across various sectors, not only health, but also other sectors, for example, education, social services, in order to address the broader determinants of health and provide more holistic response to crisis. We have discussed also what is the resilient and how to measure it. And we saw it is challenging task to measure resilience because situation can be changed rapidly in the course of the shocks or crisis. Next point is related to the financial protection, ensuring that health services remain affordable, especially during the crisis, protects against financial hardships that can be exacerbated health inequalities. We saw yesterday Ukrainian case of emerging considerable number of private providers during the current crisis, which was actually surprising for me, the increasing so rapidly number of private providers. In general, public-private partnership is very important during all crisis. However, we should question how accessible are the services of those private providers for vulnerable population. Do they can apply them without high financial hardships? This is a very important question. And of course, adaptability and flexibility, primary healthcare system must be able to rapidly adapt to changing circumstances, such as shifting resources or alternating service delivery models without losing their core role focus on comprehensive care. Also, it's very important is the integrated health information system. I think it is very important component, and we did not talk about it much yesterday, but I did it because I think it's very important. Also, to have some integrated health information system, efficient interoperable health information system that enables real-time data collection, sharing, and analysis are vital for quick decision-making during the crisis. We also talked about potential of telemedicine in times of crisis. There was some various opinion about it, but here important task is to clearly define referral pathways. Lots of telemedicine services are not utilized simply because of referral pathways are not defined. So to summarize, in order to achieve realistic primary healthcare systems in the times of crisis, we need continuous investment in primary healthcare infrastructure, workforce, and technologies. It should be accompanied by strengthening health system governance. Effective leadership and governance are much needed to coordinate responses, allocate resources efficiently, and maintain transparency during the crisis. Establish partnership with other actors and civil society to address the social determinants of health, and leverage additional resources and expertise is equally crucial. At the same time, we need to ensure that all intervention and responses prioritize most vulnerable population to prevent widening health disparity during the crisis. And last but not least, reflection and learning is very important. Of course, we should promote continuous learning and adaptation. After each, this is one of the gaps that we have, what I now we mentioned. After each crisis, system should be evaluated their response and integrate lessons learned to improve future preparedness and resilience. And in this context, we need also to have more comparative research, and it is one gap in our region, to better study and compare the situation during crisis among the countries of our region. This is all what I wanted to say, and maybe my group member will add something which I missed during the presentation. Thank you for your attention.
Maybe other group members who were part of the do you want to contribute? Okay. Maybe then we will take a couple questions, suggestions. Is any of you interested in the primary healthcare? Yeah. Okay. Thank you, Simon. Oh, Alexander, can I ask you if somebody will just raise a hand, on the line, please just inform us and put people on mute. Can we see them? Okay, great. Please introduce yourself.
Just trying to orient on the microphone. Okay, my name is Katerina Ostrovska. I work for the USAID Health Reform Support, and my field is health workforce planning. So I will try to be precise and concise. And since we have been discussing governance, it's a kind of a plea to jump into the discussion, because I have very brief notes taken. So I'm just also ask you to be involved. And actually, if we are going one by one, and we start by the pitch delivered by Simon Wigley, we did realize that there is a huge connection track between the democracy, autocracy, the rule in general, with the outcomes of the health system. So in this regard, during the talk, we realized that we do not possess the information how it's happening during the wartime. So actually, I guess Elena quite directly pointed out that there is something that should be discovered further, because Ukraine in this case would be very good example for the study. And we should probably search for indicators to work with. And one of them have already been mentioned in avoidable mortality, cause-specific mortality, and so on and so forth, which was probably maybe also we should work over this bulk of the indicators to be tracked further. And next, I would say that from what I've learned from the talk by Dina Balabanova, so we can be very I'm just trying to look through my notes. Well, it has been also delineated that we should look at the trust at the social institutions, because as we have heard in Ukraine, we do still have a mobilized public, but how it's going through this period, we still do not know how these changes influence on the level of our quality performance throughout many of the indicators, because now in Ukraine we do not have them introduced nationally and even regionally, so it's not something to be tracked regularly. It's much more on ad hoc basis. Then we discovered from Natalia Kovalenko's talk such an issue as the informal payment. So as we can see, there is a part which is seen from the patient side, and it was complemented by Solomia saying that WHO also does this from another point, from the governmental point of view. So it might be a kind of a good traditional way to combine all this look from one point and from another. So just a good way of analyzing and deploy this research on a permanent basis to understand how the system performs. Further, we have seen from Anais Ismail talk that there is also some problems in building the liaison between the governmental sector and non-governmental sector. So there is a kind of a regulational part, and probably it also should be discovered in Ukraine, because just sorry for me all the time talking about only my country in particular, but if you have something to add on top of your country, so it will be also welcomed. So what I'm saying is there's something to be also taken on board with regard to the professional self-governance. It's a kind of a complementary talk to this part delivered by Radmila, because we still has not adopted the law on the professional regulation. There should be the second hearing in the parliament, and only after it will be deployed. So we should probably realize what kind of best practices, what kind of any other regulatory parts to this process might be introduced and might be applicable specifically to Ukraine under the angle of the war or aftermath period. So it's something to be developed further. Well, without any further ado, probably I will just pass the word to my lovely colleague. So thank you.
Thank you. My name is Özge Karada. I am a medical doctor and a public health researcher working at BAU, Istanbul School of Medicine. Maybe I can add a few gaps in knowledge and practice. So I believe the evidence about the relationship of democracy, corruption, inequities, and health is actually adequate. Like, we know the link by research. Of course, we can have up-to-date evidence, but the gap exists in implementation and evaluation, probably, like how to make sure that we properly address political determinants of health, democratic institutions, equity, justice, inclusion, adequately in policy making, laws, practices, and how do we measure these and compare indicators between countries in a standard way. How do we train future health professionals on these issues and linkages, like we make sure that they are also aware of these relations? And then how do we work more in a more multidisciplinary way? Like how do we how health professionals collaborate more with political science, social science researchers? How can we increase community participation, use participatory research, policy making more to address all these issues? And probably also how do we increase the overall awareness of the public on these, democracy, corruption, and all these linkages with their own health, like the community health. And lastly, I can also add maybe how we can use technology, AI, and other tools to basically monitor all these indicators and maybe update our surveillance systems to understand the effect of certain policies, interventions, practices on health and public health status. So those are my notes in the gaps. Thank you.
Colleagues, hearing what we heard, do you have some like additional reflections? Because like we were looking and hearing very active engagement on this session a couple hours ago. Maybe you had something in addition to add or some possible ideas and maybe suggestions, or maybe we missed something. Okay, I guess no. Yeah, it is. Thank you very much. Thank you, both of you. And please applaud. Thank you. Okay, do we have like online participants? Maybe some of you have some additional or final remarks to do? Okay. Hearing nothing. Once again, we would like to thank you, all of you, for being part of this conference. And before we will go back home, Alexander, may I ask you to put the code? Yeah, please put it. So when I started this morning, and it had been mentioned during the first day as well a couple of times, the main aim, okay, maybe here, yeah, the main aim of this conference is to bring stakeholders, bring researchers together from the region, and maybe in the future we will have possibility to collaborate, and also to increase the in the region. Even we can do it by ourselves. I'm sure there are many people in the region who are great health economists or health financing specialists, and we can exchange our experience. And we developed this kind of very simple LinkedIn group, and we are encouraging you, just scan it and be part of it. And imagine that if you one day are going to do research, for example, you are sitting in Ukraine and you would like to have, or in Armenia or whatever, like other countries you are working in, and you are going to have study like on immunization, for example, and you are looking for partners who are working on it. Maybe this will be a platform where you can just post a question. So I'm looking for that kind of people. Are you interested? Or, for example, you are developing curricula, or you are working on some capacity needs. So maybe this will be a platform where you can find your partners to work on with. We can start with the simple LinkedIn group, and then let's see how big the network will be. Then we can move to like maybe more well comprehensive and well operating like platform, but we need to make a first step as a society in the region. And like if on this is on the one hand, but on the other hand, let's let me once again try to encourage you to become members of Health Systems Global. This is like professional network, society of people who are working on health policy systems research and health system strengthening around the world. So I guess on that note, we can close the session. And hopefully, I don't know if we have, Adrianna, do we have some like final remarks maybe from you? I don't know, Mark, if you are here with us. Yeah. Oh, really? Sorry, we will try to do it. Can we do it once again? It doesn't work in anybody's like in. Ah, okay. Is it, sorry for technical issues. We will do it right after we will be sharing like some material. Yeah. Okay, so, or can we announce, Anna, can you remind me how it's called, like? So HSG, Europe Regional Network of Health Researchers. But we'll still send the link by email to all of you. Thank you very much. I know, Adrianna, do you want some final? Yeah. Thank you. Thank you. Have nice flights back to your countries. Bye.